for here today. So today I'll be presenting on increasing cancer screening through for low-income individuals through an academic community clinical partnership, but I'll be focusing on our work that was related to colorectal cancer. Just trying to streamline what I present. So I thought I'll give a brief background of how I even got involved with this project in the first place. So I had come from Nigeria, my home country, with various interests, one of which was understanding strategies for reducing breast cancer related disparities. Had some personal family friends, and I had patients that made that something I was concerned about. And then I came, and there was this project that had just colorectal cancer. So I was pulled into that. At that stage, I didn't know anything about colorectal cancer, and I didn't even know disparities existed in the United States for that matter. So it's been an interesting project that I've been very happy to be associated with. Okay, doesn't look like it's working. Sorry about that. Yeah, there you go. Thank you. So I want to acknowledge the principal investigators of the project. The lead was Dr. McClellan, who is now retired, but was a family medicine physician at the Texas A&M Family Medicine Center. And then Dr. Jane Boulding, who was my advisor, is a professor at the School of Public Health, Texas A&M. And then we had a team that comprised of our community partners, the community health workers, the graduate students, and the physicians who actually perform the procedure. And as you would expect, the team has been evolving. So I thought I would start by talking about colorectal cancer in Texas to kind of provide an overview of why this project was even necessary at the time when it was started. And then I'll give a brief overview of colorectal cancer, describe our project, and then talk about our results. And in talking about the results, I'll largely focus on 3 peer-reviewed publications that we have, just to present major findings that we've had, and then talk about the future work that I'm hoping to do related to this. So at the time this project was started, which was about 2011, colorectal cancer was the second leading cause of cancer-related deaths in Texas. And Texas was ranked 41st in colorectal cancer screening. So that clearly was a problem. And then when we looked at mortality rates in Texas, look at the disparities by race, specifically non-Hispanic whites, non-Hispanic Blacks, and Hispanics, you kind of see that when you look at incidence rates, number of new cases occurring, you see that non-Hispanic Blacks had the highest incidence rates. When you look at mortality rates, you also see non-Hispanic Blacks having higher mortality rates. So there was a racial disparity too occurring at the time. So now our project was focused on an area that's called the Brazos Valley region. It started with 7 counties. So the Black, we started with the 7 county region highlighted in the black, and we eventually expanded to 17 counties. So at the time that we started this project, you can see that 12 of the 17 target counties had higher than average incidence rates when you compare to other counties in the states. The same way, when you look at mortality rates by county, 8 of our target counties had mortality rates. So this was also problematic. And so this was part of the reason why this project was even considered in the first place, and we're fortunate to get funding. So I thought I would give a brief overview of colorectal cancer. Currently, it is the 3rd leading cause of cancer-related deaths in the United States. And this is an interesting cancer when you think about it from the prevention point of view, because it results from malignant transformation of lesions or growths in the large intestine, referred to as polyps. And so, meaning that these polyps don't start out cancerous, but when they live in the colon for 5 to 10 years, then that's when they are likely to become cancerous. So when you think about it from the point of view of prevention, you see that this is a prime cancer for preventive strategies, because if we get rid of the polyps, then most likely we don't have the cancer. Unfortunately, currently, the CDC estimates that about 1 in 3 age-eligible United States residents have never had a colorectal cancer screening. So again, that's a problem, because routine screening can prevent about 60% of colorectal cancer-related deaths. So again, we need to get people to start being screened. Another problem with screening is that disparities exist. There is disparity by race, by ethnicity, by income, by educational attainment. So this is a key cancer that we should target in terms of increasing awareness and increasing screening rates. So screening guidelines. So the United States Preventive Services Task Force is the body that uses synthesizes evidence-based research to provide guidelines on screening activities, screening-related activities. So for colorectal cancer, for individuals who don't have any family history of colorectal cancer, it is recommended that screening occurs between the age of 50 and 75 years. So once you're 50, you should start considering, you should get a screen for colorectal cancer. And there are various screening modalities out there. There is the annual high sensitivity fecal occult test, which has to occur annually. There's sigmoidoscopy that can occur every 5 years, accompanied by a fecal blood test every 3 years. And then there is screening colonoscopy every 10 years. And so colonoscopy is regarded as a gold standard. Some people will quarrel with that statement because it's usually said that the best test is the test that gets done. But people sometimes refer to it as the gold standard. It's the most sensitive and it's one of the 2 specific tests. And why it is a unique test is because it allows visualization of the colon at the same time as removal. So you can remove the polyp, during the procedure if you see it. The other reason is, so you see we have sigmoidoscopy, which is also a type of endoscopy, but it only gets as far as the sigmoid. So this is the colon, right? So and this is the sigmoid and this is the cecum. So the colonoscope can actually get to the cecum, so you can see the whole colon through that, while the sigmoidoscopy goes as far as the sigmoid part of the colon, which is why you need to have a follow-up fecal test. So again, it's regarded as the gold standard, but the best test is actually the test that gets done. So regardless of screening modality, we want people to get screened. So, but there are barriers to screening. There is a system level barrier. The system can be very complex and can be difficult to navigate for a lot of people. So that alone can become a barrier to screening. There is inadequate capacity. There are some areas that don't have, for example, gastroenterologists who typically perform this procedure. So that becomes a barrier. Communication, provider communication is another barrier. One of the papers that I'll be looking at to explore provider communication. And why this is important is because it's been shown that when patients are told about colorectal cancer screening, they tend to get screened. So, but it's also been shown that usually in provider-patient interactions where colorectal cancer is discussed, is usually the patients that bring up the topic. So again, the patient is a crucial agent in this communication. And so if we make them aware of the guidelines through community outreach, for example, then we're equipping them to have the efficacy to go in and have that discussion. Individual level barrier, lack of health insurance. The fecal test is annual. It's a lot cheaper, but assuming you have a positive test, you need to go get a colonoscopy. And at the time we had this grant, I believe the cost was about $800, and this was in 2011. So, so it is an expensive test to pay out of pocket for. There are other self-perceived barriers, like the fear of a negative outcome, lack of knowledge, whether lack of knowledge of screening guidelines, of lack of knowledge of what the process even entails, have been found to be barriers. Language barriers, cultural barriers, medical mistrust, health literacy. And health literacy has been defined as the ability of an individual to obtain, process, and understand health-related information that they can then use to improve their health. You know, I'm paraphrasing. And this is problematic because it is estimated at the time we started this project, it was estimated that about 80% of adult Americans had either marginal or inadequate health literacy. And colorectal cancer has been associated with, inadequate colorectal cancer has been associated with suboptimal screening. So this is something that we also need to be aware of in prevention, either to find ways to improve health literacy or to find ways to identify those patients so that we can provide targeted navigation to them. So the Texas Cancer Screening Training Education Program, which was funded by the Cancer Prevention and Research Institute of Texas, is a project that involved collaboration with a medical center, which was the Texas A&M Family Medicine Center, the School of Public Health, and many community partners. And we had various strategies. So this we were very fortunate. This project didn't just fund education and outreach, it actually paid for the screenings. So that was part of why we were able to be as successful as we were, and as they continue to be even till now. So they provided funding for colonoscopies for people who were low income or who were uninsured. So the first strategy was to increase referrals and access. Remember, one of the barriers I mentioned was provider capacity. So patients who live in very rural areas or in medically underserved areas had a problem with accessing colonoscopy. So one of the strategies that was involved was to collaborate with community organizations in those areas to talk about this project and to encourage people to self-refer to the medical center if they thought they needed, they were age eligible for screening, or they had symptoms, or they had a family history of screening. The second strategy that was used was to collaborate with local primary care providers. So we routinely went to primary care providers in our target counties to let them know about this program, to provide them with the referral forms that they can use to refer patients. And then community education and outreach. So we went to health fairs, religious organizations, community-based organizations that worked with low-income individuals. We went there to talk about colorectal cancer and to talk about our project. Another barrier that I mentioned was cultural barriers, which is difficult to measure, but the way we try to overcome that barrier was by providing culturally relevant case management. And we did that by using promotoras or community health workers who are traditionally defined as members of the community who are versed with cultural practices and are able to help patients overcome cultural barriers that might prevent them from getting screened in this instance. The third strategy was to train family medicine residents to perform colonoscopies, which you can imagine is a challenge when you think of turf wars that traditionally occur in medical practice, because this is something that is traditionally performed by gastroenterologists. And so now you want to equip family medicine residents to perform this procedure. So you need to prove that it's feasible and it actually works. So we will also present results from that. And of course, the final strategy was data analysis and dissemination, which was mostly what the public health partners did in addition to the community outreach, disseminating our results through media, through local media, through peer-reviewed publications, through conferences. Okay, so results. So I'll start. So my sample size is going to keep fluctuating because this paper's you know, we wrote papers as we progressed in the study, so sample sizes will fluctuate, but our demographics was largely the same. We was mostly 44 to 45% Hispanics. We had a lot of problem recruiting African Americans for some reasons. So this is generally what our demographics look like. We think we were particularly successful with the Hispanic population because most of our community health workers were Hispanic. And so, but even when we look at it by between female, male, it was mostly females, and we only had one community health worker. We didn't test that statistically, but we believe that, you know, it's kind of mirrored the barriers that we try to talk about, trying to have people whom people can relate to. By counties reached, the largest county reached was Brazos. The Family Medicine Center was located in the Brazos County, so it makes sense that most of the patients will come from there, but we also had quite a few coming from the other counties. So I'll briefly talk about the peer-reviewed publications. So the first paper that we wrote was examining variations in self-reported barriers to colonoscopy. So literature has shown that barriers exist, but to the best of our knowledge, at the time we wrote this paper, any demographic variation in self-identified barriers had not yet been demonstrated. And this was important to us because as we were implementing our intervention, we wanted to be able to tailor our intervention to various groups, because we had partners that were providing transportation. We had events where we talked about screenings, we talked about barriers, and sometimes, as you would imagine, there were demographic variations in people who came to those meetings, depending on who the organizers were. So if we knew whether there were variations, it would help us as we tailor our intervention. So that was one of the things this paper set out to do, including adding to literature. So the objective was to examine whether there are demographic variation in self-reported barriers to colorectal cancer screening using colonoscopies. So we were restricted to white, African American, or Hispanic just because of the numbers that we had. So we had to exclude the other racial groups. Our outcome variables were self-reported barriers, and these were Likert scale questions about barriers. And then because they were Likert scale, they were ordered, we used ordinal logistic regression, and the final sample size was 382. So the first question, you know, so they have, as patients come to the clinic or as we performed our community outreach, we had our survey asking them various questions, including to what extent do you think the following items are barriers to getting screened? So most people agreed that cost was a barrier, then the fear of finding cancer, anxiety, lack of knowledge, embarrassment, and so on. So then we looked at the barriers and we're trying to see if there are demographic variations in the barriers. So of all the barriers that we listed, the ones that showed some demographic variation was lack of transportation. And so we found that Blacks were more likely to identify lack of transportation as a barrier. And again, this was crucial for our project because we had partners that were providing transportation assistance. So if we have this information, it kind of helps you when you're relating to people to be more aware or more sensitive to questions that you should ask. Hispanics were more likely to identify fear of cancer as a barrier, and you know there's a lot of this in literature about fear of cancer among Hispanics as a barrier to colorectal cancer screening. And then those who had less than a high school education were more likely to identify lack of knowledge as a barrier compared to those who had some college education or those who were college graduates. Then we also explored barriers by having previous colorectal cancer screening using colonoscopy. And we found that those who have never been screened were more likely to say they were embarrassed or they lacked transportation or anxiety or lack of knowledge were barriers to screening. So again, this is an important information to have as you implement your intervention to increase screening. The second paper that I wanted to talk about was our paper looking at the role of health literacy and communication habits on previous colorectal cancer screening among our patients. And again, health literacy is the ability to obtain, process, and use health-related information to make your health better, paraphrasing. And it's been associated with colorectal cancer screening. People who have inadequate health literacy are less likely to get screened. Provider communication, again, is an important variable because when providers discuss colorectal cancer screening with their patients, the patients are more likely to get screened. And then patients who, in interactions where that communication actually occurs, studies have shown us that it's usually the patients who bring up this topic. So again, another potent variable that you can target with interventions. So our objective was to examine whether health literacy and provider communication, patient-provider communication, explain the relationship between educational attainment and previous screening. And our thought was that, so we know that previous screening increases with increasing educational attainment. And so we're wondering whether that relationship might be moderated or explained if you account for health literacy. And so that was what we wanted to explore. So we used multivariable logistic regression. It was a binary outcome variable. Have you ever been screened for colorectal cancer? Yes, no. Our predictors of interest were educational attainment, health literacy, which was we used a previously validated one question item that asks how confident you are completing medical forms, and it is a Likert scale from strongly disagree to strongly agree. And then provider communication patterns were captured by also a previously validated question, asking 3 Likert scale questions. 1, how often do you prepare questions before you visit your provider? How often do you ask for clarification during the provider visit? And then the third one, I am forgetting. But so we generated a composite score of that question to explore this. The final sample size was 456. And so the major findings were that there was an association between having less than a high school education and not reporting previous screening. However, when we control for health literacy in that model, that relationship ceased to exist. So the conclusion we drew from this was that health literacy is an important variable to consider when you're looking at interventions to increase screening among individuals who have lower educational attainment. The other thing we also saw was that with decreasing health literacy, there was a decreasing likelihood of saying that you have ever be screened. There was no association between provider communication and previous screening among our study sample. So the final paper I wanted to touch on, remember I talked about family medicine residents performing this procedure, and it's supposed to be performed by gastroenterologists. So we wanted to see what the Association of American Society of Gastroenterologists have what they call quality indicators that are like benchmarks that you use to know what the quality of your colonoscopies are. So we wanted to see how the quality by these family medicine physicians and residents were measuring against that standard. So there are a couple of indicators, what is called cecal intubation rate, which essentially means how often do you get to the cecum, which is the terminal part of the colon, because you want to be able to visualize that. The adenoma detection rate, the adenomas are lips, so you want to be detecting that, right? Since we know that they are the lesions that eventually become cancerous, so they want to know how often. And then the average withdrawal time. So the slower you are in removing your colonoscope, the more likely you are to see the polyps, right? So you want to make sure you take your time after you have intubated when you're bringing out the colonoscope. So those are the quality indicators. So the cecal incubation, and these are our proportions. So the cecal intubation rate is calculated as number of procedures in which the cecum was attained over total number of procedures performed, the adenoma or adenocarcinoma detection rate. So we calculated both for our study, but usually it's the adenoma detection rate is number of procedures where adenomas were detected over the total number of procedures performed. At the time we were performing the study, our sample size was over 1,100 patients that had been seen at that time. So that's the American Society of Gastroenterology recommendation is there, and then we are reporting C-STEP quality indicators. So you see that the first one, as the SIRC attained, the society recommends having greater or equal to 95. For our program, we had 96.25. So we were well above the quality indicator. For adenoma detection rate among females older than 50 years, remember, colorectal cancer screening is recommended, if you don't have a family history from between 50 and 75 years. So the society recommends having detection rate of greater or equal to 15. We had 25.96. For males, they recommend greater or equal to 25. We had 38.15. And then they recommend withdrawal time of greater or equal to 6 minutes. And our average was 18 minutes. The perforation rate, so one of the complications of this procedure is that occasionally, unfortunately, the colon can get perforated. So they recommend that you shouldn't have a perforation rate of more than 1 in 1,000. At the time we were doing this study, we had over 11,000 and we had only had 1 perforation in the colon. So this procedures that were provided by family medicine residents were met and even exceeded the quality indicator. So again, when you think in terms of access and capacity for low-income, underserved patients, so that this is a potent strategy in trying to improve colorectal cancer screening among this demographic group. So practice implications. We couldn't have done what we did without partnerships. We partnered with community organizations, we partnered with media, with the radio, with the newspapers. The word was out there. We went to churches, we went to community-based organizations. We had people give us tables during health fairs so we can talk about their program. We went to back to school events. We put flyers in the kids' backpacks. So there was just no way we could have done this without the partnerships that we had. We had a lot of our patients could not access, could not come to the clinic because, so colonoscopy, you have to do the prep, right? So you have to go and do the prep, and then you, no, you had to go and do the what's it called? I forget what the term they use, where they tell you about the procedure, what to expect on the day. Then they give you the thing that you're supposed to drink for the prep. And then you go back home, and then you come back again to have the actual procedure. And so when you think of transportation as a barrier, you see how that becomes a problem. And so our community partners were very helpful. We were doing colonoscopy preps in churches, in halls, in food pantries, so that people could come to places that were close to them. So they only had to travel once. So this project just would not have worked without the partners that we had, especially our community partners. So another practice implication is that interventions need to be tailored, right? We can't do a one-size-fits-all. If we are serious about reducing the disparities, we have to be careful to identify as much as we can barriers that are specific to certain demographic groups. And then primary care providers do play a role. And this, again, there is hesitancy by the professionals who traditionally should perform this in allowing primary care physicians to perform this procedure. But the capacity is just not there, right? There are areas that just don't have access to gastroenterologists. So if we are serious, we need to start considering this as an option. And we have shown from this project that there is indeed a possibility. And one of the things about this program was that a lot of their graduates did go ahead to practice in areas that were underserved. So this was crucial to the program and also to the patients that they eventually saw. So any questions before I go ahead and talk about my future research? Okay, so I thought I would just mention what I moved to Arizona last year. So I'm still trying to develop collaborations, and I am interested in continuing with this research. And I thought I would just present what I'm hoping to do But first, I thought I'll talk about colorectal cancer in Arizona, right? So when you look at this map of incidence rates and mortality rates in Arizona, you kind of see that it almost looks as if we don't need to do any colorectal cancer related work in Arizona, right? Because as the blue increases in intensity, the numbers are increasing or the rates are increasing. And so you see that it's almost white for incidence rates, and it's almost white for mortality rates. So when you look at this, you might think that, oh, you know, you really don't need to do any work. But then when you begin to get more granular, the disparities begin to show themselves, right? So we see the disparities by county. We see the disparities by race. And so when you look at this, you see that this is rates of new cases. See that one of the interesting things here is Blacks have a lower percentage of new cases, but the rate of new cases, but they are having higher mortality rates. So disparities showing that when you look at the disparities by male, female, you also begin to also see that disparity showing up among Blacks when you compare to whites, and also just having even this deaths occurring from colorectal cancer when we know we can prevent it. It provides an opportunity for us to implement interventions. So two approaches I am pursuing is, first of all, getting state-specific data, whether it's population-based surveys. I've obtained the behavioral risk factor surveillance survey, which is it's a survey that's asked, among several questions, cancer-related questions. And so I've been fortunate to get the information from Arizona. And why it's important to have Arizona-specific data is that they allow you information on FIPS code, which can help you then. The national data doesn't give you FIPS code at the county level. So you can't really get down to the county level. The state data will do that for you. And so having that data will be helpful as I continue with my research. The second thing I hope to do, in Texas, we were able to use a Texas Cancer Registry, which in Texas is a very wonderful data set because they give you information up to the census tract level. So I am pursuing that option here. It still hasn't occurred, but hopefully it will eventually. And then, of course, collaboration with local providers as I try to further my research in this area in Arizona. So thank you very much for having me.
Thank you. Does anyone have any questions? Yes.
Really great presentation.
Thank you.
Ojinnaka. So with my clinical hat on, I wanted to raise another question. Really phenomenal work, really showcasing what we, come to see across so many different areas of medicine, and with your focus on colorectal screening, clearly there are profound disparities, and you've done great work addressing some of the structural barriers to care. But one area that I'm interested in, I'm wondering if your team kind of looked at that, is looking at, great, we can actually increase the skill of family medicine providers to perform the technical skill of colonoscopy. But what about patient-provider interactions? What about provider trust? We do know, there is a long history of historic distrust of physicians, distrust of the healthcare system, implicit bias. We see, whether looking at heart disease, stroke, all these other morbidities, we always see that underrepresented minorities tend to be less likely to be counseled or offered certain interventions or offered, certain treatments, and that disparity, is consistent across many different disease processes. What did your team, or is it something you're thinking about for the future? So looking at patient-provider interactions, patient-provider communication, implicit bias, race and ethnicity of the provider, and all these other things that often don't get measured in a quantifiable way in a lot of these large-scale studies, but do play an important role when we think about the larger, social determinants of health, of which that is an important piece, in terms of really ongoing care, loss to follow-up, and ultimately outcomes for populations. I mean, you see the last slide you showed on, even in Arizona, Blacks having lower incidence, but mortality is still higher. That definitely speaks to that. Once they're in care, do they stay in care? Do they fall out? What's the level of interaction with providers? Implicit bias that might certainly influence their compliance and ultimately outcomes.
All right. So unfortunately, we didn't have any specific intervention. That was one of the reasons why we, wrote or explored provider communication in our survey, which was not significant in our study. I would say, though, that that's why, in my mind, community health workers remain a very important workforce, right, as we try to address disparities, because these are people who actually can relate to the people. So in talking about communication, that was one of the things the community health workers really helped us with. So when you talk about loss to follow up, I remember there was this particular patient who had been called over and over. So the strategy was you call when the patient indicates interest. So you go to the community, you talk about this, and you say, you can call us, right? So once they call, you call them back. Oh, we got your call, or we got the text saying you'd like to get screened. This is what the procedure looks like. Would you like to come in? Yes, we schedule you, okay? And then you're supposed to come in for the prep. So then we had this patient who, and then so we schedule you for the prep, and then if you miss the prep, we make another phone call. If there is no response, we send a mail. And then if there is no response, then we say we've done our best. Well, the community health worker said, no, this guy actually needs it. There is a family history. And I believe she had the contact of a relative, and then she calls a relative and finds out, oh, he actually works the graveyard shift. So this whole thing is not going to work. And they were able to work something out. So that's the way we try to, circumvent that communication and follow up, but it's an important thing to look at. We just didn't look at it in our project.
I think also training providers is critical. Not
Right.
just the technical skill of performing a procedure, but also what are the things that you need to be aware of so you don't write a patient off as
Right. Right.
Or
Right.
assume certain things that they might be aware of these other structural barriers. I think a lot of providers just don't have the additional sense to think outside of just their technical skills
Yes.
about the barriers that can impact the patient's compliance.
Yeah, that's very important. Yes. Yes.
Great job. It's a very informative talk.
Thank you.
I had a question about the health literacy, the measure that you use for health literacy. I don't know if you know as much about it, but I'm going to ask it anyway. So you used a 1-question scale.
The CHEW.
Yes.
Yes.
And so have you compared that scale to others? There's those scales out there that have them look at medicine bottles and other things that can really kind of more objectively than asking how do you feel about it, get at what a person's health literacy is. So I wondered, one, if you compared the 1-question scale, because 1 question is always really great. So if you had compared the validity and those responses to those other scales, and if not, I don't know if you know this, but what was the variation in the answer to the 1 question? So if everybody's piling up on the I feel real good section, or was there some good variation in the answers to the 1 question?
Right. So we did not compare. We just took the author's word for it that they had validated their tool against other people. But that's it. And I've got that question. So it's something that we definitely need to consider. The variation, there was good variation. I don't remember it right now, but I know that people were dispersed. So we started with the 5. So we started with the 5 questions, and there was dispersion with so it's 5 like a scale, right? Never, often, sometimes, always. I forget the first.
Strongly disagree.
Right. So there was dispersion for the middle and the 2 extreme. So we merged for agree, disagree, and then to kind of take care of that variation. And so that's why we had marginal where always and some strongly disagree, agree, adequate, strongly agree, adequate, sometimes marginal, and then never, often, inadequate. So that way the dispersion was even more.
So was there variation, and did you evaluate it by race, ethnicity? Certain races tend to answer in the more confident way than other races. For example, African Americans, if you ask them about self-esteem, tend to fall all onto the, I'm not telling these white people that I don't know something, so I'll fall into the, sure I know. So did you analyze it by race as well?
I don't think we did. And this was about a couple of years ago. I don't think we did, but we did control for race in the model, in the multivariable model. Yeah. Race was a control variable.
Thank you.
Thank you.
So one of the things that we may be able to help as well is on your future work for analysis and state-specific data. So I'm Omar Contreras, and I work for the University of Arizona Cancer Center under Dr. Hatcher's team. And one of the things that we're currently looking at is doing heat maps of the burden of cancer by primary care areas. So we're digging a little bit deeper with a collaboration with the Arizona Department of Health Services to not look at county data, because as we know, and going beyond the BRFSS system, looking more specifically at the primary care areas to look at the burden of cancer, say colorectal, and maybe that could also help with your future interventions, with future work. I know that's one of the things that we're looking forward with our outreach program, as well as how we could strategically identify these pockets where we could concentrate our efforts into those communities of further need. So definitely there's room for synergy within your work, and I think the work that we're doing, and we'll be more than happy to kind of sit with you and look over the data that we currently have to help you enhance your work.
That's very exciting. Thank you, and I look forward to that.
It's for online. Oh, sorry. Thank you. Hi, thank you so much for your presentation. I had a little more of a question. If you can walk us through how the funding worked for the actual screening and the testing, just because I guess I'm curious to know, did you mention this in the introduction as you were recruiting participants for the study? I think that would significantly contribute maybe to my, interest in participating in the study, but also, if cost has always been a significant barrier for me and you're going to pay for it, then it might not necessarily be a barrier as maybe transportation or what have you. So I'm curious to know kind of how that was scripted in the study and recruitment, but also how do you think what are the implications of that particular, no longer having a financial barrier, right?
Yeah. So that was part of why we felt a little bit confident with our data, maybe more confident than we should feel, but we do feel confident because we told them that this was, so there are a couple of things, right? So the literature tells us that when we take care of costs, either subsidized or free, people tend to get screened. But even when you take care of costs, a lot of people still don't get screened. So providing insurance or paying for their screening is no guarantee that they will actually get screened. So that's one component. During recruiting, they were told that and again, getting back to trust, we were categorically told that this was not a research, or not to ever mention that you're doing a research when you're in the community. You have a program that wants to help people. And because we need to report to our funders, we need to ask you some questions that we're also going to have to publish. But it was not called a research per se. But we did tell them that they would have subsidized or free screening if they are not insured or if they were underinsured, which was why it was interesting to still have a lot of people identifying costs as a barrier.
It would be interesting to randomize the scripting. I think this was Dr. Krista's point where you could potentially script out this trust and engagement piece to reduce fear, reduce, other potential kind of just personal, stigma towards that type of screening, and then see if you bring up the financial in the beginning to kind of understand and tease out, does the engagement piece weigh, right, that engagement piece. And I'm pretty sure that the engagement piece, I know just knowing the literature and stuff, would probably outweigh the financial. That you can give me $1 million to do something, but if I just don't like to interact with doctors, I just have this fear. I don't know. I don't want to know if I can. It doesn't matter. People are just not going to show up. But it would be interesting to see kind of how that variation might potentially play out. Just simply by the script, which
Right.
could be a very interesting pilot.
Yeah. Thank you.
Thank you. So I probably have more technical questions as I'm not at the minimum age for colorectal screening. I did. So now on TV, at least, I see all these commercials about the fecal blood testing that you can do at home.
The Cologuard? Is that the
Yeah.
Cologuard? Okay.
How does that play in? I know this was kind of before that, but how do you anticipate that at-home test kind of playing into people getting screened? And if colorectal screenings or colonoscopy is only recommended once every 10 years, how do you think that would play into it? Do you think more people will get tested now? Do you think it will reduce some of the disparities and barriers? I know this is hypothetical, but
Yeah.
I'm curious.
So I can't speak specifically to Cologuard, but I will say that the other fecal tests like the FIT and the other ones are the same premise. It's just I think Cologuard is more sensitive. That's why it's becoming more talked about now. But those ones are, it's more convenient for the patient. It's less invasive. There is this icky factor, but people still tend to do it. And it's also less expensive. The challenge with the fecal test is the repeats, right? Because it's something you have to do every year. So when you think about the system level intervention, so sometimes you need to set up reminders to, remind the patient. So if you drop the ball, then you might miss that. The patient needs to remember. So which is why people say you have to always say the best test is the test that gets done. So people tend to prefer colonoscopy because it's 10 years, you do it and then you forget about it. But then there is also the cost factor of colonoscopy compared to the fecal test. So there is the pros and the cons for both. Yes, Krista.
There's work that in the cervical cancer literature actually of HPV testing using home swabs showing improved uptake in patients who would otherwise not be screened. So that model has been shown as a potential model that, potentially does have ramifications for colorectal screening, but they've shown it for cervical cancer.
I have a quick question. Thank you for your presentation. It was very informative. And thank you for considering culture as part of the model here. And it seems like, for what I understand, your team was more successful with the Latino community than with the African-American community. And it seems like the Promotoras model was effective. You tried to replicate the Promotora model with the African-American community, or didn't you? I'm curious about that, because it seems that health navigators will be very effective also with the African-American community.
Right.
I'm curious.
Yeah. So it was interesting. We had an African-American community health worker. And when we had her, our African-American patients went up. Unfortunately, we lost her. And then it went back down. So again, pointing to that cultural, it's something that you just can't overlook if you're trying, especially if you're trying to reach underserved patients. So that was something interesting that we saw in our data. So, yeah.
Any other thoughts, questions? Well, help me think. Doctor, I'm going to get your name right. Ojinnaka.
Yes. Thank you. Thank you. Thank you. Thank you for having me.
And I'm very excited about your potential new collaboration that you found in Noise today.
Welcome to ASU.
Thank you. Thank you. Hi, so good to see you.